if we look at this osmolality changing, we go from 300 increasing as the water leaves. We see the osmolality increases, peaking at the bottom of the loop. And then as the sodium and chloride are leaving, we see that the osmolality decreases as we go up to the distal tubule, distal convoluted tubule. So what I want to introduce now is a very important blood vessel that's traveling next to each nephron called the vasa recta. And the vasa recta is shown in red here. The blood flow is moving with the direction I'm showing you now, following the arrows. And notably, the blood flow is going in a different direction in the U than that in the loop of Henle. So I want to show the loop of Henle. Henle is going here, going down, and then coming up. And that is the opposite orientation of the blood in the vasa recta. So the vasa recta is really important because it provides nutrients and then takes waste products from the cells that are in this part of the kidney. And it's very important for the blood vessel to work properly that this needs to be at the same osmolality as the loop of Henle. So what we see happening in the blood as it enters the vasa recta, we see it's going to be picking up sodium and chloride. As it does this, it's going to have more solutes. Therefore, the osmolality will increase to the same level that it is in the loop of Henle. Then as the vasa recta begins ascending, it is going to pick up water. And then as the water is picked up, the osmolality of the blood is going to decrease. And this is really critical because, again, all the cells in this part of the nephron need oxygen, they need glucose and other metabolites, and they also have waste products like carbon dioxide and other waste products to get rid of. And the capillaries need to pick this up, okay? But anyway, this important blood vessel, the vasa recta, is really allows for both the blood vessels and the loop of Henle to have similar osmolality. And we know that's really critical for the effective movement of solutes between, or molecules between these, between the nephron and the vasa recta. But the point is, both at the top of these, we see that the regular osmolality is restored. And here's just looking at this picture again. It's a similar picture showing we call it countercurrent multiplier system because basically the water exiting, right, basically leads to this effect of having a very high osmolality in the bottom of the loop of Henle. And then basically as the sodium and calcium, so the sodium and chloride leave, it's going to restore the lower osmolality to the filtrate. And then the same thing's happening in the vasa recta, except that its descending loop is going to be picking up sodium chloride, and then its ascending loop is going to be picking up water. So it's basically like a mirror image of this. And then here again is the vasa recta. The one thing that's weird is this is shown in my opinion, the wrong orientation to compare what we just looked at a minute ago, because the descending vasa recta capillary, this is where the sodium and chloride are being picked up, shown in black, right? And it's the ascending vasa recta capillary that is actually picking up the water. So I would have inverted this and shown it with this part being on the right and this part being on the left to be consistent, but that's not what the textbook did. But I just wanted to mention that to you because if you are a visual learner, in your mind, like kind of invert this to be left and right instead of right and left. So again, I just want to highlight this important phenomenon. So in the descending loop of Henle, we have the water leaving, right? And that's going to be leading, thanks to aquaporins, and also no permeability to the sodium chloride ions, the salt. Then it's going to increase the osmolality as the water leaves. The solutes are going to be more concentrated. In the ascending loop of Henle, we have this sodium chloride leaving via that mechanism we talked about before, involving the sodium moving with its concentration gradient, carrying in the chloride and potassium against its concentration gradient in the apical side, and then the basal side, we have the sodium-potassium pump that sets up that dynamic for sodium to be in lower concentration in the cell, and then we have the passive diffusion of the chloride ions and the potassium ions into the interstitial space. And then the vasorectus having the different interaction that's going to still lead to the osmolality. We have the sodium ions from the sodium and chloride ions leaving the interstitial space, entering the vasorecta to increase its osmolality as it goes down near the bottom of the loop of Henle. And then we'll see a movement of water into the ascending vasorecta, right, to restore normal osmolality. And again, this is critical to allow the nephron to be having proper nourishment and the removal of waste products. And again, what's happening in this net movement, we see the salt leaving the ascending loop of Henle, then entering the vasorecta, and then here we see some water leaving the descending loop of Henle and entering the vasorecta. So this is a very dynamic process with a lot of movement of fluid and salt. The next topic is secretion. So secretion is the opposite of reabsorption, right? So reabsorption, this is looking at Bowman's capsule. We have the filtration occurring first with the reabsorption, and then secretion is where molecules are going to be put into the nephron for to be urinated out of the body. So if we look at some molecules that can be secreted, one class of molecules that is often secreted in urine is drugs, and we have specific carriers in the membrane to be bringing in foreign substances into the tubules. So for some drugs are carried by organic anion transporters, which we call OATs, and then we also have the organic cation transporters, which are OX, and these carriers are very specific, or polyspecific, and they do overlap in function, but they're specific for either the anionic or the cationic molecules. These work really quickly in terms of removing molecules from the body and then having you urinate them out. And a lot of drugs are tested for the presence or absence of drug are tested in urine samples because of this process of secretion. So for potassium secretion, if we have an increase in blood potassium levels, we'll have an increase in the number of potassium channels in the distal convoluted tubules and collecting ducts. And this will lead to an increase in potassium secretion into the distal convoluted tubule and collecting ducts. In contrast, when blood potassium levels drop, these channels will be removed, so there won't be as much secretion of potassium. I just want to show you, we know that the potassium will be reabsorbed in the proximal convoluted tubule, and now I'm showing you that the secretion of potassium is regulated in the distal convoluted tubule, so then it can be urinated out. So now I'd like to look at the complex relationship between sodium, potassium, and hydrogen ions. So the reabsorption of sodium stimulates the secretion of other positive ions like potassium and hydrogen in the distal convoluted tubule. So if you have acidosis in the blood, it means a slightly acidic blood, then this stimulates the secretion of hydrogen ions and then inhibits the secretion of potassium ions. And because of this, acidosis can lead to hyperkalemia, which is having too much potassium in the blood. In contrast, alkalosis, which is having a higher pH, can stimulate the secretion of more potassium. And hyperkalemia can stimulate the secretion of potassium and then inhibit the secretion of hydrogen ions, and this can actually cause acidosis.